So again, we're going to finish up the last little bit for um, your exam three. Okay. I'm going to tell you, okay, just from experience, okay, this information is going to be super important. All right. So I'm going to start with that and really need to understand the concepts because this is usually one of the hardest parts. You guys have a lot of information on exam three, lots of chapters. So really need to focus in and, get a grasp of this. So chapter 15, we're going to talk about healthcare settings, okay? And we talk about healthcare settings, right, where healthcare takes place. And then in chapter 16, we're going to talk about healthcare financing or the healthcare system. So, like how it's financed, some issues and things like that. So, again, really important information that we need to cover today. Um, and then, of course, if we have time, then we will do some more practice questions. Um, all right. So I will share my screen. Zamira, Ramela, are you guys there? LaShawn, Shahada.
I
Am
don't
I-
know. You can't see me?
Now I can. You just turned your camera on. It was off. Shahada. What are we? Shahada, can you hear me? Shahada, can you hear me?
Yes, I'm sorry. I couldn't get my phone off mute.
Okay, can you fix your camera? Okay. All right, so I'm going to share my screen. If you're driving Shahada, you need to log off.
I'm parking.
All right, I'm going to share my screen. All right. So again, this is some really important information. Make sure that we really understand this. Um, all right. So we're going to talk again. This is going to be chapter 15 is healthcare settings. So we're going to start with that. First part of this, we're going to talk about different types of hospitals. All right. So this is, when we look at healthcare agencies, they're all not the same. Okay. You can even look some, in your community, and see that not all healthcare settings are the same. They can differ in size, they can differ in their focus, in their quality of the service, how they're financed. And so that is where we're going to start. And this slide always is really small, so I'm going to make that bigger. All right, so when we look at a comparison of healthcare agencies, we have public and we have private. Oops. Okay. So healthcare entities, again, they offer different services. They are owned and operated either by public, which is the government, or by private entities, which under private, we would have both your profit and your nonprofit organizations. Okay, so this is the major differences right here between the public and the private. All right, so we're going to start with public. All right, so we have official, which is government, and we have non-official, which are voluntary, right? So government official, they're supported by tax money. All right, so your tax money goes to support these services. They offer programs for disease prevention and wellness promotion. They sometimes will direct services of healthcare. They are accountable to the taxpayers, right? Because that's where they're getting their funding from and the government. And they offer both mandated and non-mandated programs. Okay. Your non-official or voluntary public, they rely on voluntary contributions and fees for service. Okay. They primary services with these organizations are research and education. They offer direct healthcare services. They are accountable to their supporters, their boards, and they also, their programs are determined by the supporter interest. We look at private, okay? So private they charge a fee for service. So you go to the private hospitals, right? You have to pay for those services. Their primary services are curing diseases and illness. They also may have some disease prevention and wellness promotion programs as well. And of course, their accountability is going to be to the owners. And they determine the goal or they determine their programs based off of the defined goals of the organization. We're going to break this down a little bit more. Okay. So again, your official or government organizations, excuse me, are nonprofit. They are tax supported. Okay. Um, so it means that they are accountable to the taxpayers as well as the government. They provide disease prevention and wellness programs, and then some direct healthcare services. Voluntary hospitals, all right, they are nonprofit. The first nonprofit that always comes to my head is like St. Jude's Children's Hospital, okay, and that you see those telethons and commercials and hear things about them all the time. They rely on voluntary contributions, okay? So they need they
Okay.
go ahead. I'm sorry.
Oh, I'm sorry.
No, I didn't know if you had a question. You're fine. Um, they charge a fee for service, they do research and education, they also may offer some direct health services. Again, those activities are determined by the supporter interest. So, gonna break it down even more. We look at official government agencies. At your official government agency at the local level is going to be your city or your county health department. Okay. Some people have been to their health department. Some people may have never been to the health department. I will tell you that the only time I ever went to the health department when I lived in Virginia was doing clinicals during my bachelor's program. I think I knew it was there, but I had never no, I never paid attention to what services it offered. Okay, so your local is going to be your city or your county health department. They are funded by local tax money as well. They may get some subsidies from either the state or the federal government. They carry out mandated or state laws concerning community health. Okay, so things like maybe immunizations, okay, STD clinics, that kind of thing. They also may carry out some non-mandated programs like health promotion programs, okay? They also, in collaboration with other government agencies, will respond to community health issues. So if there's an outbreak of a contagious disease like COVID, measles, chickenpox, salmonella, okay, they will respond and do an investigation. At the state, I made the slide big, now it doesn't want to move. At the state level, we also have a state health department. Okay, they are funded by tax money as well. They also may receive some money from the federal government. And then at the federal level, okay, the official health agency at the federal level is the U.S. Department of Health and Human Services, or DHHS. Okay, and if you work in healthcare now, as a CNA, you've heard of state, like states in the buildings, states come in. Okay, that is DHHS. That is the Department of Health and Human Services. It is funded by federal taxes. Okay. The agency head is somebody that is appointed by the President of the United States, and that person will advise the president in health matters. Under the Department of Health and Human Services, there are 11 operating divisions, okay, including 8 agencies in our U.S. Public Health Services. So we're not going to go through all 11 of these, okay, but we are going to talk about some. First one is the US FDA, okay, the United States Food and Drug Administration. So, you might have learned about the FDA back in pharmacology, right, with drug approval process. But the FDA ensures that food, human and animal medications or drugs, medical devices, and electronic products that emit radiation are safe and, if applicable, effective. Okay. When we think medical devices, your defibrillators, your pacemakers, your hip implants, your knee implants, your shoulder implants. Okay. All of those medical devices that we use, they need to be FDA approved. We also have the Centers for Disease Control and Prevention. Okay. Maybe some people didn't know about the CDC until COVID, but then everybody became very familiar with the CDC. They provide leadership in health prevention and promotion programs. They also respond to those public health emergencies. The National Institute of Health, or NIH, they fund biomedical research. They have their own labs. They also will fund it in universities and hospitals, even in some private research institutions and the private industry. The NIH also trains new researchers. They promote collecting and sharing of medical knowledge, so we get that dissemination. It has 27 institutes and centers, but it also includes then the National Institute of Nursing Research. So it's very big. Voluntary agencies, all right, when we think of voluntary agencies, because these are nonprofit agencies, okay? So they're complementary to the government agencies, but again, these are voluntary. We've heard a lot about these. We've heard, a lot of us have heard about American Cancer Society, the American Diabetes Society or Association. I don't know why I say society. The American Lung, the American Heart Association, Alcoholics Anonymous, La Leche League. Um, Oh, I already. Narcotics Anonymous, and I can't even say it now. Narcotics Anonymous would fall under here. So would the American Stroke Association would also fall under these voluntary agencies. And these are really great agencies. Think about it, right? If we have a newly diagnosed diabetic, a newly diagnosed, somebody that has heart disease, cancer, right? We can refer people to these agencies, right? That helps them with support groups and getting information about treatment and other options. I'm gonna have to make the slides back down to normal size. All right. So those are okay, back up here. We're gonna go back. All right. Official, you have your, got to go back. Your local is your health department. Okay, they're funded by local tax money. They may get some subsidies from the state and the federal level. They carry out state laws, which are mandated programs, and they also may do some non-mandated programs. They'll also respond to outbreaks of diseases in communicable diseases in their area. and other community health issues. The state agency, each state has its health department. And those are the ones that come in and do those wonderful inspections. All right. And then you have your official, which is your U.S. Department of Health and Human Services. That's funded by federal taxes. The agency head is appointed by the president. And here are some of those agencies that fall under that. So again, the US FDA, the CDC, and your NIH. Your volunteers are your societies and your associations. And then we have our private healthcare agencies, okay? And most of us probably are more familiar with private healthcare agencies. And so these are for profit. They can also be nonprofit institutions. It really just depends. Um, but their primary goal is for curing disease and illness. More recently, we have had a push with emphasis on disease prevention as well as wellness. Most people get their healthcare through private providers. Okay, so that's usually where, we start that entrance into healthcare. Um, so like, think about the area that you live in. Every area is different, but you may have like a chain of hospitals, right, that are all owned by like the same company. And even small groups of individuals can also own a healthcare facility as well. Um, let's see. Family practice, all right? So primary care is, where usually a lot of people have a family care provider. Not everybody, though. We'll talk about that later. Family practice physicians deliver primary care, refer to specialists, right? If additional evaluation is needed, right? Maybe you were walking and you tripped and you twisted your ankle and you go to your primary care and they're like, oh, maybe you need to go to see an orthopedist, right? And they're going to send you to that orthopedist. They'll put you that referral in for your orthopedist. Um, we also have private practice nurses, which are your advanced practice nurses. They can, counsel individuals on healthcare issues. They also, what's really nice about your advanced practice nurses is they help in those rural areas where physicians are sometimes difficult to obtain. All right. And so, they have those advanced practice nurses to kind of fill in that gap. Um, Now we're going to talk about different types of hospitals, right? So the different types of hospitals, um, we have community hospitals. So the American Hospital Association defines a community hospital as non-federal short-term stay or short-term general and your specialty hospitals. We also have federal government. All right. So the federal government hospitals are like your Veterans Health Administration. It also could be like your federal, state, or sometimes a county like psych facility. And then well, I already said that, the psychiatric. So again, our general, all right, so our general hospitals, they provide a wide range of healthcare services or medical services, but with some of these hospitals, they may not have a specialist to treat serious conditions. Okay, so they may have to, like if you go to a general hospital, they may have to, if they don't have a like specific specialist, or if it's a serious condition, they may just stabilize, right? And then once they stabilize, then they can transfer them to a different hospital. There's also specialty hospitals, and specialty hospitals offer services related to our particular disease or condition. And sometimes the specialty hospitals are associated like with a hospital like um, like orthopedic center, right, within the hospital, or a trauma center, um, cancer centers, right? They may be part of the hospital, right, but their own little part of it. They have highly skilled specialists with advanced knowledge to care for those people. Volunteer or community hospitals. These are community associations or religious organizations that own voluntary community hospitals. They are dependent on gifts and donations to supplement their revenue. Um, they will have a board of trustees, and usually there's a paid administrator that's going to manage the hospital. These will provide short-term inpatient care for people with acute illnesses and injuries, right? So I don't know about your areas, but you may, have one of these that are in your area, whether it's a religious organization, trying to think, I can't think of who owns it now, but like we had Mary Immaculate, I think it was, I can't remember that overarching, but it was, it was a Catholic hospital, okay? So it really kind of just depends on your area. You may find some of these there. Your federal or your state government hospitals, again, it's like your VA hospitals, your state, county, nonprofit hospitals. It also, again, could be your psychiatric hospitals, depending on how big your state is, right? You may have one, you may have multiple. And then we have teaching and research hospitals. So these can either be community or they can be federal, but these are usually training sites for healthcare providers, nurses, and other health professionals. They are almost always affiliated with a medical school, right? So I always think of like Boston University Hospital or Vanderbilt Hospital, or I mean, there's so many more now, I can't think of one. There's one in Chicago too. But I mean, they're all over the place. Like in Virginia, when I was in Virginia, we had Eastern Virginia Medical School. And so it was right next to one of the big campuses. They also do clinical trials at the research and training, teaching hospitals. So lots of really good practitioners that are in those areas. And then there's what we call critical access hospitals. So these are smaller hospitals. They usually only have no more than 25 inpatient beds. They usually don't stay in these hospitals longer than 96 hours. But they are open, just like a regular hospital is, 24 hours a day, 7 days a week. They, emergency care as well. These are usually going to be in more of your rural areas that have at least a 35-mile drive from another hospital. Okay. So these are, again, they're going to be in your more rural areas. They will provide care for common conditions. They will do outpatient care as well. And then again, if there's, a serious condition, then they are going to go ahead and stabilize, right? And then transfer to a larger hospital system if needed. Because that's pretty good drive, right? If something happens, think of your rural areas. Think about when you took community, right? And your vulnerable populations, right? Those vulnerable areas. Think of like farming accidents, right? Or equipments, right? That's a long drive, right? If there's like something going on, but these hospitals, like I said, they can stabilize and then transfer to another facility. All right. So we're going to go outside of hospitals now. And we're going to talk about some of the other services where, or other places that people get health care. So we have ambulatory services. Okay, so ambulatory services, they are private, they're nursing care centers, they're HMOs, they're community health clinics. So they also could be the group practices, like provider group practices, healthcare providers' offices. Urgent care centers would be ambulatory center as well. These are generally less expensive. All right. So these for people who, like, you and I, right? We live on our own, we live independently, or for people that are cared for at home. So, like, let's say you're taking care of a loved one at home, you may have access to a private, primary care provider. And they can do assessment, they can do treatment, they can also do care coordination. I'm just going to scroll down a little bit. All right. So we have outpatient clinics. So outpatient clinics, let's say patients in the hospital, um, get discharged from the hospital, they have to have somebody that's going to follow up with them, right, to make sure that they're okay post hospitalization. So they provide follow-up care to those clients after hospitalization. So they also can manage, right, diseases. Not everybody with a chronic disease, right, has to be hospitalized, right? Lots of people that are managed with hypertension, diabetes, MS, right? They don't have to be in the hospital to be managed. We can manage them for the most part on an ambulatory basis. They can be part of a healthcare facility or they can be freestanding, okay, or not attached to a hospital. And so, like, if you look at, like, I know, like, all the hospitals down here are like this, right? You have the main hospital, right? You have your emergency room, you have your inpatient hospital, right? And then you have like another wing to the hospital, and they may have provider offices there, right? They may have primary care, they may have specialists, right? But they're doctor's offices that are attached to the hospital, but they're still separate, right? Okay. Natasha, okay. Linda, are you there? Um, you do need to make an appointment, right? So they're not generally walk-in, but again, these can include your specialty areas, whatever the specialty is. Endocrine, neuro, allergy, oncology, ortho, what else? Derm, nephrology, like whatever the specific need is. My slides don't want to move today. Urgent care centers. We've all seen urgent care centers. So urgent care centers don't usually need an appointment, right? You can walk into these centers. One thing about urgent care center is they do make primary health care available as an alternative to care. Okay. So maybe you don't have a healthcare provider, all right, and don't, either what for whatever reason you don't have time or having a primary care provider, right? Doctor's offices are open what 9 to 5, maybe 8 to 4, in the same hours that a lot of people are working. Maybe it's inconvenient. So we have these urgent care centers. So again, a lot of people can use the urgent care centers as an alternative to a healthcare provider. It's also cheaper to go to urgent care than it is to go to the emergency room. Okay. And that's why, like, you see even like TikToks and you see other like Instagram and stuff like that. Like, I know they do it and it's very informative. Like, when should you go to the urgent care versus when you should go to the emergency room? But it's again, these are often used by people who don't have a primary care provider, or it's outside of those regular office hours and you still need care. Um, and the name of the or the name of the urgent care center or the center tells you what type of services they provide. All right, so we have like convenience clinics, express care, quick care, urgent care. These are even like some of them like in your CVS, what is it called? It's the Minute Clinic, right? I think it's Minute Clinic at CVS, right? You need to get an immunization. You can go to the Minute Clinic, right? So there's depending again where, excuse me, the type of service that they are provided. And the area that you live in and the population is going to determine how many of these you may see. Like when I lived in Virginia, maybe in about a 10-mile radius, I had a hospital and maybe three urgent care centers. Okay. Moving down here, within a 2-mile radius, I have six urgent care centers. It is just it's so different. And then within, depending on traffic, okay, because traffic down here is a little bit different than what I'm used to, but like within a 15, 20-minute ride, I have like a choice of like four different hospitals. Like it's just different. Um, and the urgent care centers down here are set up like, you know how like you have little strip malls. They literally are in the strip malls. Like there'd be an urgent care next to a pizzeria. Like it's just, I don't know, it's just kind of interesting. One day surgical centers. Okay. So ambulatory surgery centers. All right. Let's say you need to have your tonsils taken out. Okay. And you can schedule it through a ambulatory surgery center. So you get a time and date to go to the surgery center. You go in, go whatever time they tell you to get there. You do your pre-op, go in, get your tonsils taken out. You go into the post anesthesia, and then right once you're stable, then guess what? You go home, right? So if you don't need to be staying in the hospital overnight for whatever the procedure is, right? It's less money, right? Because you're not being charged for staying in the hospital overnight. These can be separate centers. So you may see ambulatory surgery centers, which are separate from the hospital. Or when you go into a hospital, you may see outpatient surgery and inpatient surgery. Okay. So it can be inside the hospital as well. With your same day surgeries, they do not do complex procedures. Okay. So you're not going to go in and have, a heart valve repair, okay, in an ambulatory surgery center or a same day surgery center, right? This is for like minor stuff. Like my daughter got her tonsils taken out. She got sent home. Had another one of my other daughter, not one of my other daughters, she had to have she had a deviated septum that was needed to be repaired. Brought her in, fixed it, brought her in, took her home, right? So it's not for complex procedures. It's simple procedures that it's safe for you to go home afterwards. Free clinics. We look at free clinics. This is another means of providing primary care, and it's for people who can't afford traditional health services or, they are reluctant to use the traditional services. So, with the free clinics, cost is often based on income levels. They also usually will have an age or an income limit, right? So, if you make over this amount of money, then the free clinic is not appropriate. Um, Most of your healthcare providers and nurses in your free clinics are volunteers. Now, there's usually like a salaried administrator for these too as well, but usually the healthcare providers are voluntary. And the volunteer board is going to make the policy decisions for those free clinics. Now, again, this is going to depend on where you live, the population, and if there is availability of these free clinics within that area. Now we're going to talk about alternatives to long-term care facilities and long-term care facilities. Okay. So we have skilled nursing care. Okay. Um, and so skilled care is that care that is considered um, medically necessary to improve the quality of the client's health or to maintain or slow decompensation of a client's condition. All right. So it kind of just it really depends on, what the client needs and if they are going to qualify for that skilled care. Have you guys heard of skilled care before? Has anybody heard of skilled care before?
Yes.
Okay. So long-term care facilities, we all have heard of long-term care facilities or nursing homes. They help people with disabilities or have chronic medical needs that, can't stay home for whatever reason, or maybe they don't have any family. They don't qualify for home health services, right? Because they wouldn't be able to care for themselves, right, without 24-hour care. Home health services. Now, home health, I don't know. Does anybody have an interest in doing home health? I don't know if I've asked you guys this question before or not. Anybody interested in home health?
Yeah.
Really?
Well, like assisted living,
Oh,
more
okay.
like.
So assisted living is a little bit different from home health. I thought about it a couple times and I'm like, I just don't think I can do it. I just don't like going into other people's homes. I guess that's my biggest issue.
Me
I just feel
either.
like huh?
I said me either. That's why I wouldn't do home health care. I don't want to be in nobody else's house.
Yeah, like I just don't know. Like, I mean, if a friend's house is different, right? Going to a friend's house is different, but then you feel like I'm invading their space. You know what I mean? And I'm like, just not, yeah. But home health services, obviously this is going to be different from, hospital and long-term care. There's a big focus with home health nursing on relationship-centered care, right? So we're not just building a relationship with the client, we're also building a relationship with the family, right? Or even, who maybe, it's other caregivers. Um, the purpose here is to promote, maintain, or restore health or to minimize the effects of illness or disability, right? So we think of somebody who's had a stroke, right? Of course, our goal is, we want to get them back to as close to their previous level of functioning as possible. If they've had a hip replacement, they've had a serious infection, right? We want to get them back to as previous or, as close to that previous level of function as possible. But a big part of home health nursing is education, right? So we're teaching not only just the clients, but we're also teaching their family or, whoever their partners, their caregivers, whatever. We're teaching them self-care, right? We're basically providing that education so that they can, care for themselves. So they have to be, in order to qualify for home health, they have to be homebound and they have to have a skilled need. Okay. And so services here, skilled nursing, we can do physical therapy, we can do speech, we can do occupational therapy. They may need social services. They may need respiratory, nutrition, dietary. They may need a home health aide. I'm trying to think what else. What's the difference between a home health aide and a CNA?
One is licensed and one is not.
So home health aides can be certified. They can get a certificate. But what is the difference in what in the services that they provide? So home health aides, I started off as a home health aide way before I joined the Navy, um, in Florida. And so we did we were trained to do vital signs. We were also trained, like, we would do, like, transfers, or, even take them shopping. We would, if they had to go to the doctor, but we didn't do any, like, or even some cooking. So we didn't do any, we didn't do dressing changes. We didn't do any of that stuff. It was just strictly more of a companion type service. So like my one client that I had when I first started, the only thing that she needed me for is her and her spouse were older and they were taking care of, they had a disabled daughter and she had severe cerebral palsy. And so what I would do is I would go over in the morning, I would help to transfer her from her bed to her wheelchair, and then I would go back in the evening and I would help them put her back in bed. So it wasn't, we don't, no real like no real services like healthcare services. What's the difference between physical therapy and occupational therapy?
You said physical and occupational.
Yes, ma'am.
Occupational is like ADLs, making sure you can use a spoon and things like that. Is physical is like ambulation.
Yeah, so physical therapy is strengthening, right? We're trying to get your strength up. And then your occupational therapy, yes, that is your ADLs, cooking, cleaning, doing your laundry, bathing. Good job. So we go back and circle back to these skilled care or these skilled nursing services. Okay, so skilled nursing services are provided and directed by the registered nurses. And then the LPN is going to be the one to provide basic nursing care under that RN supervision. Um, So LPNs are able to provide a lot of the home health services. All right. So again, when we look at coordinated care, right? RN, LPN, CNA, right? And other members on that healthcare team, it's focused on achieving, right, the highest level of functioning for the client. So we're trying to get them back to that as close to their previous level of functioning as possible. And so teaching, supervising, administering, or preparing medications for self administration. We can give injections, check glucose levels, treatments, and treatments, of course, wound care, ostomy care, bowel and bladder retraining, oxygen and respiratory care would also fall under this as well. Other types of care. It's always more. So we have community health nursing services, right? So you talked about community health, right? And community, the major focus of community health nursing is to improve the health status of communities, right? Or groups of people through education, screening, and care outside of an acute care setting, right? Also, may have some um, provide, other services as well, depending on the area. We have adult daycare services. Adult daycare centers are awesome. Who's anybody heard of PACE? The PACE programs, they're pretty popular. PACE is the program for all-inclusive care for the elderly. Um, It's a variety of different services, but what adult daycare centers are for. So let's say you are taking care of your mom or your grandma, okay? And maybe grandma, isn't safe to leave her home by the day, during the day, right? Because you worry about falls or, memory loss or maybe some other issues that can occur, right? So, but you're there in the evenings, you're there on the weekends, but we just worry about safety during the day. So we have these adult daycare centers, right? They just need supervision. They're not nursing home candidates because they have care, right, in the evenings and at home. And a lot of times, they'll even pick them up in the morning and bring them home in the evening. It depends on what type of center it is. But the purpose of adult daycare is to provide mental stimulation, socialization. They may also get some assistance with ADLs. They're in a nice, safe environment. And again, some of them have food, they'll have like meals and like, it depends, maybe breakfast and lunch or lunch and dinner, depending on the area. But they also may have some like therapeutic interventions. There's this one I was reading up on. It's an adult daycare center, but it also has providers. So there are providers that, if they need to be seen by, a provider, then they have those services as well. Independent living. These obviously they're, independent. They're not licensed, they're not regulated for healthcare delivery, right? So these might be like your older 55 apartment complexes, or some of the other type independent living facilities. They, do activities and trips and things like that. Your assisted living. This is a home with services. And so they, have living quarters that are handicap accessible. They want to be as independent as possible, but maybe they can't, do all of their ADLs. They will with assisted living, they do get some help with daily routine, but it's not 24-hour care. Okay. So that's one thing with assisted living. They get some help, but it's not 24-hour care, right? So they may need some help with bathing or dressing, that kind of thing. It really just kind of depends. And then you have your residential care homes. Residential care homes, these are they can be temporary or they can be long term. Um, but it's for those with occasional mild cognitive, maybe some mobility issues, and they do get some assistance as well. And they're licensed as either an adult family home or adult group home. But they will get assistance as well. And then we have our rehab services. All right, so rehab services, these focus again on the return to function and prevention of further disability. So there's rehab centers that are attached to long-term care facilities. There are also rehab centers that are separate or their own little entities. There's outpatient rehabs, right? So you have a freestanding rehab. There's the group residential homes, or we can do rehab services in the home. And nurses are a huge part of all of this. Wellness centers. And so wellness centers, I don't know, probably if you'd ask me, probably one of the least heard of. But wellness centers, excuse me, they promote wellness, they detect diseases in early stages. But we have, this is like your nutritional counseling, your exercise programs, stress reduction, um, weight control. A lot of your insurance companies now, especially with older population, are really pushing for the wellness centers to keep, people as active as possible. Um, and then we have our hospice. Um, so hospice is our end of life care, right? Death with dignity. We want, maintain comfort as death approaches. So, in order to qualify for hospice, usually they have been certified as terminally ill. They have a prognosis of less than 6 months or 6 months if it runs its normal course. That's not to say I've seen hospice patients that have, been in hospice for years, 2, 3+ years. It just really, it depends, but they do have to have that terminally ill diagnosis. Again, it's to maintain comfort as death approaches, right? Death with dignity. Hospice care can be provided anywhere. It can be provided at home. It can be provided in the hospital, in a long-term care setting. Some places have hospice houses as well. So if the patient doesn't want to die at home or doesn't want to be in the hospital, they have hospice homes as well that they can go to. Um, especially though if pain and symptom management is necessary, it can be offered in that institution. Um, and it just depends. It depends on the person, right? If they want to be home, they want to die in their own home, then those hospice services can be offered in the home. Palliative care is another one. There's a lot of students get hospice and palliative care confused. Again, with hospice, it's end of life care. Okay, they have a terminal diagnosis. Um, Palliative care, it provides comfort care. Okay, it is similar to hospice. I'm not saying that it's not similar to hospice, it is. Okay, but the one difference is we can give palliative care at any stage of the illness. Okay, it doesn't matter if they're terminal or they're not terminal. Okay, so let's see this. Take a woman who has hyperemesis gravidarum. I don't know why that just popped into my head. Okay, and they need IV fluids. That administration of IV fluids would, be helpful, right? It'd be palliative care to maintain fluid status, right? Prevent dehydration. Um, but again, yes, we often will, you know, um, provide palliative care to our hospice patients. Okay, but not all palliative care is hospice. If we're giving palliative treatments, then they may still be, receiving life-saving implementations. Okay, so take our cancer patients, all right? Maybe they're going through treatment with chemo and radiation. They have, vomiting and nausea and other issues going on related to the chemotherapy, right? And we're treating those issues with fluids. We're providing that palliative care. Okay, so again, not all palliative care is hospice, but hospice clients receive palliative care as well. Again, but palliative care can be, you can do palliative at any stage of the illness. Um, and then, yeah, so this is what I was saying. So loss of appetite, pain, nausea, sleeplessness, even help with, healthcare decision making, supporting family members as well. All right. So any questions? Any questions? Nobody has any questions. All right, let's go ahead and take a break. Be back at 3:35. Savannah, I know you just popped in. We're on break until 3:35.
Okay, I had to switch device because my thing was dying.
No worries. All right. So we're going to switch gears now. And we're going to talk about financing issues and trends. All right. So we're going to talk about the Affordable Care Act and some Medicare and Medicaid and insurance things and terms that are related to insurance. So again, this is important information. All right. That is part, again, it's going to be part of exam 3. And all right. I'll share my screen. So talking about the American or the United States healthcare system or the American healthcare system. All right, so good opener here. The US healthcare system has been described as a poorly organized and complicated maze of services that lacks preventative care, waste resources, and is very expensive. Um, and so historically, um, there's some things that, of course, would help um, that kind of contributed to this. Medicare changed from fee for service to prospective payment based on DRGs, and other insurances followed. Payment system extended to include healthcare provider payment, which led to the birth of managed care organizations, point of service plans, open access plans. There's a variety of things that changed. And even with the changes, only a small improvement in healthcare costs was realized. And so, of course, we still have issues, okay? Increased costs, we still have inequities in healthcare access. Of course, we knew that, not all Americans had access to healthcare, especially the underemployed, right? The poor also struggled with accessing care despite even healthcare coverage. Um, so, variety of issues that have occurred. All right. So and I just mentioned this, right? So managed care organizations include your health maintenance or your HMOs, your preferred provider organizations, your point of service plans, and your open access plans. Um, and so the healthcare system change results, like I said, still have some issues, but it did minimize the client length of stay, which was what was utilization management. Okay. So we tried to minimize how long patients were staying in the hospital. And again, the cost only improved minimally. We still had those inequities. So we have this. We have the healthcare reform, the Affordable Care Act. Okay, so in 2010, we had the Affordable Care Act. A lot of people, we call this Obamacare, right? When it first came out, it was signed because it was signed into law by President Obama. And it was the first wide sweeping piece of legislation to address healthcare reform in the US since 1965. From 1965 to 2010, now it's a pretty extensive amount of time, right? And so in 1965, that's when Medicare was added to the Social Security Act. So the program was designed to enhance the access and the affordability of healthcare, particularly to all citizens in financial need in the United States. Okay, so we know that it was a little controversial at first, and there were some things that were a part of it that weren't always, that weren't the best, but the law has decreased the number of uninsured in the United States. All right, so it did have a really good effect on that. Um, it established a health insurance marketplace. All right, so the health insurance marketplace was a resource where an individual, families, small businesses could learn about their healthcare coverage options. Okay, so they, you could go to the marketplace and you can see what healthcare, options were, the health plan options that were there. You can choose a plan and enroll in coverage. It also provided information on programs that help people with low to moderate income and resources to pay for coverage. Okay, so it was effective there. Um, Another thing it did is eliminated lifetime coverage limits. Okay, so for example, and I'm trying to think, I see it more. I think I paid more attention to it on my dental than I did my medical, but this is not even an accurate description, but let's say your insurance company had like a $20,000 lifetime limit. Okay. That means once your insurance pays $20,000 towards whatever care you had, that was it. That was all they were going to cover. Okay. Which meant any other medical, think about somebody who has a chronic illness or even, cancer or other things. We know that treatment is going to cost that more than that money. So it eliminated that. So there's no lifetime coverage limits. It also reduced the prescription drug costs for our Medicare beneficiaries. And it also, pre-existing conditions are covered. So this was another big issue. So let's say you had, a chronic condition like diabetes, okay? And maybe you decided that you wanted to switch jobs. You got a better job offer. Well, when you go to that, go to that job, sometimes they would lock you out of the insurance for a period of time because of that chronic condition. And then what happens? Right? You still need to have your glucose supplies, you still need to have your insulin, right? So that was another thing that the Affordable Care Act did. It got rid of those pre-existing condition lockout periods. So it was very helpful. The two most common ways to finance healthcare service are what we call fee for service and capitation. All right. So fee for service, that's the traditional way of paying for your healthcare. Um, the physicians paid a fee for each, physicians were paid a fee, sorry, for each of the services they provide, right? So and then they are directly reimbursed for most ordered diagnostic tests and treatments for illness. So let's say you go to the doctor, okay? And you have strep throat. So you're going to pay for the doctor's visit, right? You're going to pay for the lab for the strep test, right? So fee for service. They could, bill for those services. Some insurance companies don't reimburse for preventative or diagnostic tests for early stage illnesses, which we know is a huge issue, right? Because we know, right, preventative care is really important. We also know that if we find things in the earlier stages, right, we have a much better prognosis. Capitation is a set monthly fee charged by the provider for each member of the insurance group for a specific set of services. So for healthcare, or so let's say um, Martinez's health plan. All right, I'll just use that. Martinez's health plan. All right, and so Dr. Smith has 50 patients that have Martinez's health plan. Okay. So they're paying their monthly premiums, right? And then I'm sending Dr. Smith a flat, a monthly fee that's charged by him for him to care for the 50 patients under Martinez's health plan. Okay, so if he keeps his patients healthy, okay, and he doesn't have to see them as often, then he's going to make money. But if he's not keeping his patients, healthy, or the health services cost more than what the monthly fee is providing to that provider, then the provider has to absorb the cost of that care. All right, so capitation can be beneficial. It also can hurt the providers. How do we pay for healthcare services, right? So before the 1940s, right, we had the personal payment or the private pay. So if were sick, you went to the doctor, right? And if it was back in the 40s, if it was $5 to see the doctor, then you paid $5 to see the doctor. You know, you had to pay for whatever costs were incurred within that as well. All right. Um, could you imagine doing that now? I don't know if anybody, I mean, if you have insurance, you don't have, you looked at your bills to see how much your insurance is covering. You know, a typical just a provider's visit is like $300 or $400, right? So that can get pretty costly, and that's not including labs and diagnostics, and other services. So, you know, just the general cost of healthcare has discouraged that, you know, personal pay for healthcare. But we have the private health insurances, okay? And so we have private group health insurance. Um, so it pools the individual contributions for a common group goal, right? Prevention from financial disaster as a result of healthcare bills. Most employers offer some sort of private health insurance. So you go, let's say you go work at hospital A, okay? They have health insurance, all right? And you pay your monthly premium, right? Whether you use the insurance or not. It's just like your car insurance, right? You have to have car insurance in order to drive your car, right? It's against the law to not have health, to not have car insurance, right? Most of us pray we never have to use our car insurance, right? And so we have to
Yeah.
have it.
You get the fuck today or so yeah.
What's the matter?
Oh, you can hear me? I'm sorry.
Right? So we pay this monthly fee for our car insurance, right? And so that money is pooled, right? So think of like, you know, the big ones, Allstate, State Farm, I don't know, Nationwide. Is that still one? Um, so they're getting all this money from all their insured, right? And, you know, that money sits there. And, you know, you may have one person that you know, has issues all the time and needs to use their car insurance. And then you have others that may hopefully never have to use their insurance. It's the same thing with your health insurance, right? You're putting your money into this health insurance plan to have it, you know, you use it when you need to use it. Um, and you know, hopefully it's just minimal. So your private group health insurances, like some of those examples, Blue Cross Blue Shield, Cigna, Aetna, um, Amira, can you mute? Amira, can you mute?
What she say?
Can you
Oh, sorry.
mute? And then we have private, individual, non-group health insurance. Okay, so maybe you're self-employed or you know, and you need health insurance. The private and individual non-group health insurance is offered by insurance companies as well to individuals who are not part of a group. And then the premiums are based on a person's health risk and their age. I want to go back. I forgot to mention this. With the private healthcare or the private group health insurance, the Affordable Care Act, okay, it imposes penalties for large employees that don't provide insurance. Okay, so larger employees or larger employers are those that have 50 employees or more. So if they don't offer the health insurance to their employees, then they get penalized. At the same time, um, the small businesses, so less than 50 employees, they will get a tax credit if they offer health insurance to their employees. Okay, so it can be a win-win situation. So these are some of the terms that you need to understand. And I don't know if anybody has ever, you know, had to pick health insurance for themselves, but you have, these are the terms that you need to understand. So when you go out and you get that job, if you've never done this before, these are what you want to look at. So The premium. The premium is the monthly fee that you pay for your health insurance coverage. Okay. So it's just like, with your car insurance. It's a set fee that you have to pay, right, for your car insurance, your health insurance. The deductible, just like with your car insurance, is the amount that you must spend out of pocket for healthcare services before a health insurance policy will begin to pay its share. So when you're determining what program or what health insurance you want to, obtain through your employer, you want to look at how much they're gonna take out of your paycheck every, payday. You also want to see what that deductible is. If you're someone that doesn't go to the doctor very often and you've got a two or a $3,000 deductible, then you're going to be paying a lot more out of pocket with that insurance. But if you're someone that, if you have like, kids that are only needing to go to the doctor, right, you might meet that deductible a lot faster. The copayment, that's what you have to pay at the time of an office visit when you're picking up your prescriptions or hospital service. So like your copay may be like, I don't know what they are anymore, but let's say it's $20 for your primary care. Maybe it's, $30 for a specialist visit. And of course, urgent cares or hospital services might be a little bit more. So you have to look at that as well. And then this one is your coinsurance. So once your deductible is met, so 2,000, 3,000, whatever it is, the coinsurance is how much you have to pay after after your deductible is met. So it could be like 80/20, where the insurance will pay 80% and you have to pay 20%. So these are numbers that you have to look at, okay? And take all of that into consideration. Like, who are you insuring? Is it just yourself, or is it you and your kids, you and your spouse and your children? You have to look at these numbers and make that decision based off of what's going to be most feasible for you and most effective. And then we'll go into the oh my gosh, the public health insurance. All right, so we have the Veterans Administration. All right, so the US provides comprehensive health services to all veterans. All right, so you have great program. I love my veterans hospital. And then we have Medicare and Medicaid. All right. So again, this is really important for you guys to understand and to get. So Medicare. All right. In 1965, Medicare was added to the Social Security Act. Okay. Medicare is a federally sponsored entitlement program and a public health insurance. Okay. It helps to finance healthcare for all persons over the age of 65 and their spouses who have at least a 10-year record in Medicare covered employment and are a citizen or permanent resident of the United States. Okay. So you have to have paid into Medicare for at least 10 years in order to be eligible to receive Medicare. Okay. And this is again 10 years. So you have to look at your little pay stubs and you see that you have 10 years paid into Medicare. It does also provide coverage to certain younger persons with disabilities, as well as those with end-stage renal disease. Wonderful thing about Medicare, because it is a federally sponsored entitlement program, no person is denied based on past medical history. Okay, so if you're eligible to receive Medicare when you turn 65, you cannot be denied Medicare based on your past medical history. Now, there are different parts of Medicare, and this is where a lot of students get these confused, okay? So I'm going to go through all of them. So Medicare Part A is your hospital insurance, okay? This pays for inpatient hospital care, Okay. So, you go into the hospital for whatever reason, it'll pay for your room, your meals, your meds, your supplies, your tests, your, labs. Even if you're in the ICU, again, Medicare Part A is your hospital insurance. Okay. It also may pay for post-hospital skilled care services, all right, or rehab services. So let's say you had to have a hip replacement and you need some rehab after you get out of the hospital. Medicare Part A is going to cover those skilled care services. May also pay for some home health, but it just kind of depends. Okay. Medicare Part B, all right, is like your regular insurance. Okay. So Part B is not part of that entitlement. Okay. People have to pay for Part B. So this covers this is your medical insurance. So your primary care providers. It's also mental health services, any outpatient care, your diagnostic tests, labs, ambulance transport, your durable medical equipment. It also could be some of your preventative things. Okay. So A is your hospital insurance, B is your medical insurance. Okay. Um, the one thing that A and B also do not pay for is any prescription medications. Okay. So A and B does not pay for prescriptions. Part A does not care, or not care. Part A does not cover long-term care either. Okay, so be mindful of that. Now, when you look at Medicare Part C, right? So Medicare Part C and Medicare Part D, these are different. All right. So, somewhere usually around October, you may start seeing commercials on TV that will talk about how, what is it? They'll say Medicare enrollment is in, the first week of December or whatever, right? And you'll start seeing commercials for these Advantage plans. Okay. This is what Part C is. Okay. So, Medicare Part C is our Medicare Advantage plans. These are not Medicare sponsored, they're not covered, they're not Medicare. They are private companies that contract with Medicare. Okay. And again, like I said, A and B, they don't cover prescription drugs. So, Medicare Part C, this could be an HMO, it could be a PPO, it could be just a savings account plan, but a lot of your Part Cs will have a prescription drug plan in that, which, if anybody knows how expensive medications are, this is a true advantage. It is going to cost a little bit more out of pocket for the clients as well. Medicare Part D is prescriptions. Okay, so it is your prescription drug coverage. Again, this is offered by insurances that cover or that are, what do you call it? That um, they are approved by Medicare to offer the services, basically. So the thing is, though, you can't have Part C and Part D. Okay, you can't double dip. So if you have Part C, you can't get Part D. If you have Part D, you can't get Part C. So again, client cannot roll in both Part C and Part D. If you have a Medicare Advantage plan that has prescription drug coverage and you join a Medicare prescription drug plan, you'll be unenrolled from Part C. Then we have Medicaid. Okay. So Medicare again, age 65 and older, unless, some younger people with disabilities and your end stage renal disease. Medicaid was also added to the Social Security Act in 1965. And this provides medical assistance for eligible families and individuals with low incomes and resources. Okay. Medicaid is cooperative venture. It's jointly funded by federal and state governments. The federal government provides broad national guidelines for Medicaid, but each state establishes its own programs and eligibility requirements. So, let's say you live in New York, okay? And you are receiving Medicaid services in New York, and you decide to move to Jersey. All right. You may not qualify for Medicaid in New Jersey because there may not be the same eligibility requirements. Okay, same thing from going from Ohio to Pennsylvania or Florida to California. Again, each state determines the eligibility requirements. So just because you qualify for Medicaid in one state doesn't mean you'll automatically qualify in another state. Um, let's see. Um, Undocumented immigrants and legal immigrants who have not resided in the US for 5 years are not eligible. Okay, so you had to have been here for at least 5 years in order to be eligible for Medicaid. And then we have CHIP. I love CHIP. CHIP's an awesome program. So CHIP is your children's health insurance program. All right, so CHIP is, and like I said, I love CHIP. It's a great, great program. Um, and so it is a program under Medicaid. Um, and so it provides medical assistance for eligible children. All right, so it covers uninsured children up to income guidelines. So they may get free or low cost health insurance for kids up to age 19. So I don't know. I don't know how many of you have health insurance and look to see, but the continual rise in healthcare costs has resulted in annual increases in premiums for employers. Okay. So, maybe you're paying $250 every 2 weeks for your health insurance, and then you notice it's starting to go up, right? Maybe it's 300, maybe it's 350, maybe it's I worked for one company um that the majority of the employees couldn't even afford the health insurance because it was so expensive. But the Affordable Care Act requires the government to create a process in conjunction with the states where insurers have to justify unreasonably high or unreasonable premium increases, right? We expect a certain percentage, but if it's unreasonably high, they have to provide justification. They can't just, oh, I'm going to raise the cost because I want to. So we'll talk about the uninsured next. So the uninsured are your low wage employees. Okay, so these are they're employed in low wage jobs that are less likely to offer insurance benefits. And it's also your middle class. Some of these workers are unemployed, okay, or they may be priced out of the health insurance market because of the rising health insurance premiums. All right, so I am just going to use McDonald's as an example. And I'm going to use $10 as an hourly rate, okay? Just because it's easier to do math, right? So let's say I make $10 an hour. I work a 40-hour week. That's $400 before taxes, right? So 400 a week, that's $1,600 a month, all right? So maybe they do offer health insurance, and you look at that health insurance and you see that your health insurance is going to cost you, $200 every, or let me think of it. Let's do Yeah, if you get paid twice a month, right? So that's what I say. It's 400 a week, so 800 every 2 weeks before taxes, because I haven't touched taxes yet, right? But your insurance is gonna come to $200 every 2 weeks. All right, so 800 minus 200, that's 600. Still haven't taken taxes out, right? So depending on what taxes, right? That significantly decreases the amount of take home pay. So that might not be affordable for some of these, right? Unemployed or underemployed, or they, the high premiums just don't allow for them to have access to the health insurance because, right, they got to keep a roof over their head. They got to, they may have kids, right? There may be other things going on. So we know that that is still a huge issue. So when we look at the uninsured, and the alternatives to pay for healthcare, so we talked about Medicaid. Okay, if they qualify for Medicaid, then they absolutely can apply for Medicaid, right? If they can afford private pay, but I imagine that if they're, underemployed or low wage employee, they're probably not going to be able to pay out of pocket for healthcare because it's expensive. They can see if there's charity care or maybe those free clinics, right? That may be available, but they could also face medical bankruptcy. I remember a time, and I'm old, okay, where if you were delinquent on your medical bills, it didn't affect your credit score, okay, because they couldn't report those medical expense or those outstanding medical bills. Now they do, right? So if you have all those medical bills, they want their money, okay, so that they can put somebody into bankruptcy. The lack of access to healthcare prevents them from getting preventative care, okay, and seeking treatment when a healthcare problem is, developing, which causes a delay of care. Or sometimes they, get treatment during the later stages of illness, right? And that's a greater expense because then we know that if it's later on in the illness, right, then it's going to be more expensive to treat. Their prognosis is also more poor. Um, and then many people rely on emergency departments for all levels of healthcare because of that lack of health insurance. And that's, it's crazy because going to the emergency room is so expensive, right? So, they don't often think like what the expense is. They just know I'm sick, I need to be seen. And like we were talking about the urgent cares earlier, right? That is a more effective option for them than the emergency rooms because the ERs are going to be more expensive. Um, let's see. All right. So we're going to go back and I touched on this a little bit at the beginning of the chapter. Just like a quick overview. All right. But we have this prospective payment system or we have the PPS. Okay. This again, this is a reimbursement that pays a predetermined fixed amount per patient admission, regardless of the actual cost to care for that patient. Okay. So the payment amount is based on a classification system, which is called a DRG, which is a diagnosis related group. Okay. So the government's going to tell Hospital A, okay, if you have a patient that has a stroke, this is how much money you're going to get to care for that patient. Then if you have a patient that had a heart attack, this is how much money you're going to get to care for those patients. So the hospitals know in advance, okay, what they are going to receive as far as reimbursement for the care of that client. And so the goal with the DRGs and the prospective payment system was to give a financial incentive to the hospitals to contain costs and resource use. Okay, so that cost containment. Problem with DRGs and that prospective payment system, we often have those abbreviated hospital stays, which lead to a reduced quality of care, also leads to an increase in readmission rates. Okay, so it's got good parts to it and it has bad parts to it. Again, hospitals know exactly how much they are going to receive for reimbursement. Okay. Um, and the goal there is to try to get it within that amount of money or less so they can make a little bit of a profit. So again, that DRG is the diagnosis related group. Okay, it's a attempt to stop the ever increasing cost of healthcare. It uses a math formula to arrive at the fee the government is going to pay for that hospitalization. And again, the hospitals are told in advance how much they are going to get. And the fee is going to depend on what DRG category it is. And so again, it's flat fee for every DRG category. Now you can have more than one DRG category. I was just using a basic, okay? If they have multiple issues coming on, like they had a heart attack and they had hypertension and they have diabetes, like, and everything is kind of going wonky at the same time, there can be multiple DRGs, not just one. Okay, so keep that in mind. And again, no matter how long they stay in the hospital, they're only going to get that flat fee. So that's why it is that incentive, right, to treat and discharge them as quickly as possible. All right. So quality, safety, and cost of healthcare. So the improving quality in healthcare. All right. So when we look at improving quality in healthcare, we have CQI. And this is a really big one. So continuous quality improvement. So what this is let's say you have, it doesn't matter, you had a fall with a fracture. Okay. So we had a patient fall and they broke their hip. All right. And what CQI does is they're going to, get all that investigation from that fall and they're going to review what happened. Okay, what were the circumstances around when the patient fell, how he fell, what happened? Okay, so it's a retrospective review, okay? And then they're going to come together and they're going to focus on preventing that from happening again in another client. Okay. So an example of CQI would be a checklist. All right. So I love a checklist. Give me a checklist and I'll go down that checklist and make sure it's all done. Right. So, whether it's an intervention, whether it's a process, right? If there's a checklist that helps you remember to do it all. The aims of the IOM, so the aims of the Institute of Medicine for improving quality in healthcare. There are 6 aims to the IOM. And so this is called STEEP, STEEEP. S is for safe, so avoiding injuries to clients from the care that's intended to help them. T is for timely, reduce waits and harmful delays. The first E is for effective, so provide services based on scientific knowledge, right? So your evidence-based practice. Your second E is efficient. Avoid waste of equipment, supplies, ideas, energy. The third E is equitable. Okay, so we want to provide care that doesn't vary in quality because of personal characteristics, right? Gender, ethnicity, geographic location, socioeconomic status. And then P is for patient-centered. Okay, so provide care that is respectful and responsive to individual client preferences, needs, values, right? And ensure that the client values guide all clinical decisions. Other area for improving quality in healthcare is your continued competency and continuing education and certification. So you must always, once you become a nurse, need to be able to demonstrate competency. Okay. So current nursing licensure considers nurses from all levels of educational preparation, minimally competent. Okay. Upon receiving the initial license. So when you graduate from nursing school, you have the minimal competence in order to do a nurse's job, and your continued competence is assumed throughout your career. Okay, so you're continually updating yourselves with your continuing education. In looking at improving safety in healthcare, we have a couple of things that fall under here. The first one is the Joint Commission and the National Patient Safety Goals. All right, so we know safety is a huge part of what we do. All right. So, think about your ethical values. Do no harm. Um, so we always have to look at that. There are different national patient safety goals for different areas. So you're going to see NPSGs for hospitals, you're going to see them for ambulatory care, you're going to see them for long-term care. Okay, so they're not all the same. The NPSGs are different based off of the area that you work in. So, for example, and I'm gonna skip it for a minute because we're gonna go into it again. And then we have the National Patient Safety Foundation. And so they partner with clients and families, community to improve client safety by avoiding those errors of commission and errors of omission. All right. Then we have I love this program. This is the Transition to Practice. So Transition to Practice, which it was an initiative by the National Councils of the State Boards of Nursing, or NCSBN. It was aimed at improving the quality and safety of healthcare by improving new grads' transition to work. And so NCSBN developed an evidence-based transmission and practice model. And so it's like a 9 to 12 month program, and it's to help new nurses transition into practice. And it's a really good program. I don't know how many hospital systems have implemented this program, but I'm telling you, it's an awesome program. All right. Couple other things here. We'll have what is called pay for performance. All right. And so I don't know if you've heard this before or not. Okay. But a big thing now with care, it isn't just about providing quantity care, it's about the quality of care. All right. Um, and so we look for pay when we look at P4P and we look at never events. All right, it aligns payments with the client outcomes. And what this means is if we have a never event, and who can tell me what a never event is? Has anybody heard of a never event or a sentinel event? No.
Like somebody
So go ahead.
like a fall or something like that.
Right. So never events are seriously and highly preventable events. Okay. So hospital acquired infections like your catheter associated UTIs, your central line infections, your uh, ventilator assisted pneumonias, or it could be injuries from a fall. So we talked about that man that fell and broke his hip. Okay. That's a never event. All right. So it's serious and highly preventable events. The hospital is not going to receive reimbursement for that. So if your patient falls and breaks a hip and they have to have surgery and a hip replacement or rods and things put in their hip, the hospital's not getting reimbursed for that because they didn't provide quality care. Okay. Same thing if they even get if they develop a catheter associated urinary tract infection. Okay. That's not quality care, right? Maybe we, slacken on the Foley care, right? They're not going to get paid for that. So again, it's about the quality of care, not the quantity of care that the patient's receiving. You can go in and out of that patient's room 100 times a day. All right. But if you're not providing quality care and free from injury, free from infection, and free, then we're not providing that quality care. Hospitals, again, the hospital's not going to get reimbursed. They have to eat the cost for that, for whatever that infection is, whatever that injury is. The other issue here, we talked about this and we said, when I said that the DRGs, right? It's about, you want to get them in and obviously we want to, stabilize them, but the goal is, right, to decrease the length of inpatient stays. We also have this other issue. We have what's called a readmission reduction program. So if a hospital discharges someone too soon, or if they are not like in the best condition and they get readmitted to the hospital within 30 days, then the hospital is going to receive a reduced payment for the care of that client. So this is for your heart attacks, your heart failure, your pneumonias, your COPD, your hips, your knees, your CABG surgeries. If they get discharged too soon and they end up back in the hospital within 30 days, that hospital is going to get a reduced payment. Okay, so this right here is, how do we improve those transitions in care when they're going from hospital to home, hospital to a skilled facility or to rehab? All right, how do we improve that process? Okay, so a lot of this is intensive education as well as providing follow-up services, right? What follow-up services are we providing for them? I already talked about that. All right. So the Joint Commission's National Patient Safety Goals, I said we were going to come back to this. So back in 1999, I know it's forever ago. So 1999, the Institute of Medicine produced this report. It was called To Err as Human, Building a Safer Healthcare System. It estimated that 44,000 to 98,000 Americans die each year as a result of medical errors. Okay. Majority of them were medication errors. Okay. But this also is your like wrong site, wrong procedure surgeries. And so one of the biggest things that's a common link between medication errors and the wrong site surgeries is your client identification. Okay. So nurses are often involved in client prep for surgery and marking the site so no confusion exists during the surgical process. So I'm going to tell you, I have had many surgeries on my left ankle. So every time I would get ready to go into surgery, the nurse would ask me, "Hey, what's what ankle are we working, or what part of the body are we having surgery on?" Show my left ankle. She'd put a big old X on my ankle. All right, come back in the provider. He would be like, "Okay, what are we doing today?" And I would say, tell him, and he would put his initials. Okay, so now I have a big X and I have the doctor's initials on my leg. All right. Why? Because trust me, I didn't want this surgery as it was, let alone have it on the wrong foot. All right. So we have to be really mindful of this and making sure that we're doing the best for our patients. So again, like I said, there's different national patient safety goals depending on what area of healthcare you're working in. So these are the NPSGs for long-term care. We have improve the accuracy of resident identification, improve the safety of using medications, reduce the risk of healthcare associated infections, reduce the risk of resident harm from resulting from falls, and then preventing healthcare associated pressure areas. With our hospital national patient safety goals, client identifiers, it's a big issue. It doesn't matter where you are. Making sure that we are using two identifiers to identify our clients. Improving effectiveness of communication. SBAR is a great way to communicate. Medication safety. Reduce harm associated with clinical alarm systems. Reduce the risk of healthcare associated infections, making sure that we're identifying client safety risks, preventing mistakes in surgery. So again, want to prevent that wrong site, wrong procedure, wrong person surgery. So what can you do? So again, big driving force in healthcare agency is going to be cost containment. Okay, so we need to hold costs within fixed limits. So you have a big part in this. So one, always follow whatever your policy is for charging clients for supplies. And so some hospitals have Pyxis systems, which is not just for the medications, but it also could be for some of the supplies. So make sure that you know that policy. Make sure that you're documenting care. Who are my CNAs? Raise your hand if you're a CNA. I know there's some CNAs. So I know because again, I'm a skilled nurse. I'm a skilled care nurse. So what are they always telling you about your documentation? What is the one area of your documentation that they're probably always fussing about making sure it's accurate? Turns, what and my ADLs, right? How many patients assist is it, right? Is it one person? Is it two person? Are they minimal assist? Are they maximum assist, right? We have to make sure that we are documenting that appropriately, right? If they're completely bedbound and they're, 450 pounds and they're a two-person max assist, and you have them, documenting that their supervision early, that's gonna reduce your reimbursement for that client, right? So making sure that, and that's just an example, but make sure that you're following policy for documentation. Organize your client care for effective and use of your time. So you need to have that really good time management skills. Be efficient and effective in delivering care. Okay. Do it right the first time. You shouldn't have to keep going back and doing something. If you don't know how to do it, ask for help. Okay. Dressings are expensive. A lot of this stuff is expensive. Okay. You don't want to use more than what you need. Make sure that you're implementing nursing care measures to help prevent complications. So Linda said turning and repositioning. Absolutely. Turning and repositioning, pressure relieving surfaces, right? Gel cushions, making sure that we're doing proper Foley care, that they're getting their chlorhexidine baths, whatever it is. You want to do everything in your power to try to prevent any complications from occurring. And I mean, they are going to be, of course, client-centered, right? We have to meet the client's needs, not our own, right? So they're always going to be involved in their care. Let's see. All right. So talk a little bit about this when dealing with change. Um, so change is inevitable. Okay. 100%. Change is inevitable. Okay. Change happen all the time. Can happen on a daily basis, can happen on a weekly basis. All right. And those of you that work in healthcare as CNAs or other, assistants, med assistants or farm techs, whatever it is, right? We know healthcare changes faster than I think anything else does. And there's different ways that we can look at change. Okay. You can be a victim, you can be a survivor, or you can be a navigator. Okay. Victims look at change in a negative way. Okay. They fear the worst is going to happen because of the change. They feel helpless in the situation and they are not willingly going to participate in the process of change. So that change is going to control them. The survivor resist the change, but they're going to go along for the ride. They'll say that it's never going to work. Okay. And if they are right, they're going to be the first ones to say, I told you so. Um, and then the navigators, okay, they feel in control of the situation. They feel confident, excited about the possibility of being part of the solution to the problem. Okay, they feel like they have control over change rather than being controlled by the change. Like I said, change is inevitable. Sometimes it can make you a little uncomfortable, right? Because you get used to doing something a certain way. And now you have to adjust your way of doing things. But just know in nursing and healthcare itself, change is inevitable. All right. So when you're out there, and you're developing a personal plan for change, you need to be able to present yourself as an LPN, LVN, as an invaluable member of that healthcare team. Okay. So things like being self-directed, being motivated. I always say be a problem solver. We all know that one person that's always going to run to management and be like, this isn't working right. This isn't working right. This isn't doing this. She's not doing this. This person isn't doing that. And da da da, da, right? Can go on and on, right? Don't be that person. Okay. If you see that something isn't working appropriately, instead of just saying, this isn't working, how about going to your supervisor, your manager, and say, okay, I noticed that this process isn't working, but I have a plan to try to fix it. Okay. So, again, be a problem solver, right? Identify what needs to be done and do it. Collaborate when you need to collaborate. Be flexible. Okay. Again, healthcare is ever changing. You need to be able to be flexible. You also need to identify tasks or protocols that can be done more efficiently. And that's why I said be a problem solver, right? If you recognize something that's not working right, needs to change, present a solution to have it fixed. Use your critical thinking skills and be a role model. This is one of the biggest things. Nobody wants to work with a negative Nancy. Okay. Um, and if you go in and you're a negative Nancy, guess what your CNAs are going to be? They're going to be a bunch of negative Nancy's. You set the tone for your unit. Okay. You set the tone for your unit. You get to go out and be the nurse that you want to be. Okay. And so just remember that, your CNAs are going to look up to you as nurses. Okay. So if you go in there with a positive attitude, even in the midst of chaos, okay, they're going to see you able to keep your cool, maintain professionalism, and they will follow suit. Not all of them. You'll always have one or two. Not going to lie, but you're the role model now. You're going to go out there and you're going to be the role model, just like the RN is going to be the role model for you. You're going to be your role model for your CNAs. And so remember that. Don't be, well, I'm not going to say don't be. You get to choose the nurse that you want to be. I'm going to leave it at that. Okay. So, however you decide to be, whatever nurse that you decide that you're going to be, okay, then that is how, your staff and your CNAs are going to um I'm trying to think. So that's just some food for thought. um we all know negative nurses. We've also, I'm sure that you, in your clinical experiences, have had great nurses, have maybe not had the greatest nurses. And you get to take all of those experiences and determine how you want to be when you finish and become a nurse. So I know this was a lot of information. I know that this is a lot of information. And so um, and I will, because nobody came to the review. So I will post exam reviews from previous terms. I'll post them in the announcement, so you'll have those available. But this, this is a lot of information on these last couple, the last couple weeks. So are you sure nobody has any questions? Okay. Um, let's see. Okay, so next week is exam 3. Um, um, so next week is exam 3. After the exam, we will do the HESI review. So we'll take the exam and then we will come and we'll do the HESI review. I will finish grading your papers, and then other than you have exam 3, you have your HESI, and then you have one last set of Saunders questions. And that is all that is left for this class. So like I said, hopefully we'll have your papers here by the end of the weekend. And then exam 3 next Friday. And then once HESI is done and everybody has completed remediation, I will turn your homework grades on. Don't forget, we will still meet in week 12. So we will not meet in week 11. So we'll meet in week 10 and we'll meet in week 12 for attendance. All right. Well, if you guys don't have any questions, I hope you guys have a great weekend and a great week, and I will see you all next Friday.
Thank you.
You're welcome.
Have a good weekend.